Thank you for tuning in. My name is Dr. Riley Clark. I'm a general dentist. I practice in Heber City, Utah. I run the Whitecap Institute. It's a dental implant training center. And I'm excited to have you join me. I'm going to talk about a really fun part of dental implantology, and that is the fixed implant supported options that are available for our patients. This is a great topic as it makes a meaningful impact in the patients that we treat and is an exciting, fun clinical treatment that we as providers get to provide to our patients. So thank you again for joining in. Excited to jump in. To get started, I wanted to just make sure I delineate a couple of different things as I talk about full arch fixed. Today we're going to be talking about the type of prosthetic you're seeing on the right side here. This is what I would call a fixed hybrid. Hybrid meaning it has the white teeth and the pink gingiva. This is sometimes referred to as an FP3 restoration, as opposed to what you see on the left, which would be an FP1. As I have tackled a lot of full arch cases, I've come to really appreciate the complete control that the prosthetic on the right offers me. As a clinician, when I'm able to provide adequate restorative space and build a prosthetic that has both the white teeth and the pink gingiva, I'm able to idealize the relationship between the pink and the white, making a more natural, beautiful prosthetic. And when you have control over all of the elements of your restoration, I feel like it's a more predictable restoration for the patient and for the doctor. And so today I'm going to be focusing my remarks on the FP3 or the fixed hybrid prosthetic you're seeing here on the right. Now, these prosthetics come in a lot of different flavors and sizes and shapes. I've had a lot of experience with full arch and I've done it a lot of different ways. I'm excited to share kind of my journey with that with you. Today, this is the workflow that I'm following, and I'm really excited to have a workflow that is linear in its function and gets me from A to Z a lot more efficiently than any workflow I've done before. We're going to jump into this a little bit later, but I want to talk a little bit about my evolution of full arch implantology. So, like I said, I've done a lot of these cases. I've done a variety of different ways. And if I had to highlight some of the big factors of how these cases are done, it would come down to these 6 components right here. First is the implant placement. How is surgery being done? The second is what type of temporary teeth are you giving the patient the day of surgery or maybe the next day? What is it made out of? What is its design? What is it attached to? What is your impression technique? I've done a lot of different impression techniques. How are you getting a proper bite registration? This to me has been one of the more complicated parts of full arch implantology. And then are you doing a prototype set of teeth? Are you giving the patient some type of teeth that they can use that basically allows them to have a sneak peek of the final teeth, so there's no surprises when you get to point number 6 here, your final delivery. So I've done it all a lot of ways. As it comes to implant placements, I've done freehand guided, tooth support, soft tissue support, bone support, implant guides, lots of different methodologies there. Temporary teeth, I've done about everything you can imagine for temporary teeth. When it comes to impressions, I've done all the different impression techniques you can do. And so as you can see, my experience with all of these different components of implantology has given me a broad spectrum, a broad view, if you will, of what's possible out there. And I've been able to, over the years, kind of fine-tune the methodology that makes the most sense for me. And so today I'm excited to show you a little bit of where I was, what I was doing, and then what I'm doing today and what that looks like most recently, as there's been a few modifications to my workflow over the last year, 18 months. And so with that said, like I said, I've done a lot of different styles. And I've always wanted a workflow that was more consistent, more predictable, and more linear in its workflow, never taking a U-turn, stepping back, needing to redo steps like rebuilding new temporaries or taking a secondary impression. I wanted something that followed more of a linear path. And so I've tried a lot of different methodologies. I've had good luck with some of them. I've had bad luck with others. And I'm excited now that we get to show you a little more predictable way. So here's a few examples of how I've done some cases. Here's some more examples of building temporaries. And then here's a more traditional temporary where we do a denture conversion. After the implants get in and the denture teeth get modified for a pickup or some type of provisional is made, I'm often asked now with the question with some of the doctors I teach, what now? What do I do now? And this is where the workflow really got complicated for a lot of doctors. A lot of doctors knew how to put the implants in. They could give the patient some type of teeth that day. But now the question is, what do I do moving forward? And I thought a lot about this. And as I thought about it, I like to look at it in this type of perspective. How do you transfer 6 pieces of data to the lab? If you can transfer these 6 pieces of data to the lab, I think they can predictably build you a new set of teeth, maybe the final teeth, in a way that is efficient and that is satisfactory to you and the patient. So number 1 is the implant position. Number 2 is the VDO. Number 3, the tooth contours, meaning the teeth, the temporary teeth they have currently. Where's the smile line, the aesthetics? And then number 5, the bite registration. And then lastly, the soft tissue. Now, what's tough with some of my historic workflows that I've used is all of these different data sets would come from a different diagnostic record. So for example, I might take a fixture level impression, and then I might build a verification jig for the lab to help capture the implant position. To get the proper VDO, I'm using probably some type of bite, block, or index for the lab so I can create the proper vertical dimension of occlusion. The teeth that I'm trying to give the patient can be captured in a picture or maybe an impression of the temporaries. Same with the smile, bite registration, again on a bite block. And then sometimes the soft tissue might change during the process of temporization and prototyping, and you might need to take another impression. Now, I don't have an issue with all these different diagnostic records. The issue is this. All these different diagnostic records are beautiful and accurate by themselves. However, as you begin to lay these records on top of each other and create relationships of one to another, sometimes they do not align themselves in the most congruent fashion. And when that happens, I found in my workflow, despite a good lab, despite wonderful diagnostic records, I found sometimes that things were amiss. Something didn't line up right, something didn't look right, something wasn't just perfect. For example, you can take an impression of the implants with a fixture level impression. And you could take an impression of the temporaries before they were removed from the patient's mouth. However, how do you relate the tooth position relative to the implant position if you had 2 separate impressions showing those 2 separate data sets? One, the implant, and one, the provisional teeth that you probably worked very hard at to make them look and be the proper aesthetics and function for the patient. That sometimes is tricky to do. And so the data sets are good, but how they relate to each other can sometimes be frustrating, and you might get outcomes like this. This is obviously a disastrous outcome where the bite was clearly not communicated properly to the lab. But this is one of my cases. This can happen. You thought you gave good data, but maybe it wasn't as accurate as you wanted, or it wasn't referenced relative to each other in the way that you wished. And then you have, disasters like this. And, this is a big disaster. I'm talking more the smaller disasters that can happen. The midline's off a little bit. The tooth shape or contour is a little bit poor. The position of 8 and 9 is a little too anterior, giving a patient a more full look than they want. Maybe the buccal corridors of the smile don't look as full or as negative as they should be. Those are the sort of things that need to be looked at and perfected. And if we're following a linear path with good data, then I think we can accomplish that more accurately, making your schedule more efficient and the process more enjoyable for the patient. So with that said, let me show you how I'm doing this today with a few modifications from what I was doing just a year ago. Again, here's my workflow. And I can't emphasize or overemphasize how important step 1 and 2 are to this process. The diagnostic gathering of scanning maybe dentures, scanning their teeth, getting a proper CT, and aligning everything to each other is really where all of this traction meets the road. And so we have to take really thoughtful diagnostics. We need to take photos that help the planners understand where the smile is, where's the lip pull, where's midlines, what's our desired outcome for the final teeth. And then digital planning, it might take a week, it might take 10 days to get a thoughtful plan so that everything moving forward is going to happen as predictable as possible. So number 1 and 2, very, very important. Really good diagnostics, really good digital planning. The implant surgery itself, because of guided surgery and DO's really accurate guide system, is frankly getting easier and easier. Not to say that it's not complicated or without risk or challenge or frustration, but I'll tell you, the implant part of this workflow to me is now becoming maybe one of the more simple or easiest part of the entire workflow because of guided surgery. And if you haven't tried guided surgery with some of your full arch cases, I would really encourage it. If you've had bad experiences in the past, I'd say give it another try, because I think it's a lot better today than it has been historically. And the DO system for me has been a game changer with its accuracy, ensuring a wonderful passive fit of my prosthetic for same day delivery. Making a fixed provisional. And then step 5, scanning the provisional. That's what we're going to talk about this later as we go through this. And then final delivery. So that's our workflow today. There are no U-turns, if you will, in the workflow. It is a linear path left to right, every step complementing the next step. And that creates extreme efficiency. So with that said, let me just share a couple of thoughts on planning. If you're not used to how this is planned, one thing I really like about working with DO and their lab is I get a printout like this emailed to me. And this right here shows a reference of the plan. Where are the implants positioned? What are the bony boundaries around them? What does the whole situation look like? What's the size of the implant? Where's the prosthetic teeth? What's the angle of the abutments? All of that is thoughtfully planned and communicated to me. And then I just need to log in, look at the plan, and if I love it, I hit confirm. And if there's some modifications, then I can submit some changes to the plan that I deem necessary as the provider. But the fact that we have thoughtful planners that will work up the whole case, plan the prosthetics first, and then the implants to match the teeth, that's a wonderful solution. That's going to provide tremendous predictability to the final restorative workflows. And in my experience, by doing it this way, the patient, the doctor are both much, much happier because we get to the final product sooner and in a more predictable fashion. Like I said, the implant surgery itself, pretty straightforward. The guides fit wonderfully. Following the drilling protocol that DO has for each implant leads to a predictable drilling sequence, often leading to really good primary stability. And then once the implants are in, good stability, good parallelism, then we're ready to actually proceed to temporary fabrication. And the temporary fabrication is expedited because of the accuracy of the guide. Everything lines up, providing a passive fit to everything to fit. And what I mean by that is, let's imagine these implants are just now placed and healed. We're now going to put multi-unit abutments into the implants. This is an example of a multi-unit abutment here, receiving a temporary cylinder on top. So here you see 7 implants placed, multi-unit abutments in place, good tissue, good healing, and then temp cylinders are going to be put in place. The temp cylinders now are attached directly to the multi-unit abutment. These abutments can be a straight abutment or an angled abutment. That is all determined in the planning phase of the treatment. There's another angle of them. And then here's the temporary that is provided. And what I love about the temporary, it's a very thoughtfully made temporary. If you see some of that additional white structure near the flange on the buccal, that provides some soft tissue guidance to the proper seat and position of the teeth. And then if you notice the palate, it has a palatal rest to help maintain the proper vertical. And then you can see we have pre-drilled holes for where the implants and the temporary cylinder should be emerging through the temporary. This next slide is where the magic really happens. And you'll see here that, look at the accuracy. So this temporary was fabricated the same day the surgical guide was fabricated. The implants obviously had not been placed yet. But DO's very thoughtful drilling protocol and extreme accurate outcome allows for a beautiful passive fit. Now, if you didn't have a passive fit with something like this, you could obviously modify making those holes a little bit bigger, but we want to be careful we don't do that too much because it might weaken the integrity of the prosthetic. So here, the appliance is put in, vertical dimension is maintained because of that palatal rest, and then with it all properly aligned, we can now inject some type of dual cure material and do a pickup. So here I'm injecting material and I'm going to make this prosthetic a screw retained prosthetic here by injecting this material. So there you see the material injected in place. That will bond to the temporary material and then mechanically lock on to the temporary cylinders. And with that in place, now you simply undo the screws and that prosthetic can actually be removed from the mouth. And then some of the void areas that you see aren't filled in all the way, final touch up and modifications can be done extraorally to help ensure that it's all designed and filled in perfectly, not creating food traps, creating ideal contours of the temporary. So pretty cool system here. Just takes minutes. I mean, when all of this lines up just right, like I showed you here, the prosthetic part of this whole thing is maybe a 20 to 30, 35 minute process, which if you've done a lot of full arch cases, you would say that's a lot quicker than normal because I've spent hours doing some of this provisional conversion. But again, this is the beauty of following a workflow that's linear. These teeth were designed and known before surgery happened. The implants were planned relative to the teeth. And then a surgical guide was printed that allows me to drill in a very accurate fashion so that the implant and its angle or trajectory matches beautifully with the temporary prosthetic. And so thoughtful planning preoperatively leads to extreme clinical efficiency. And that's what we want as a business owner, as a practitioner. And that's obviously what I think what a patient would want. You'd rather spend a little more time planning and preparing so the actual procedure or event goes smoothly and without complication. So the prosthetic is then modified, the palatal strap is removed, material is added in to make it more ideal contour and shape. And then once it's all nice and finalized, that's a beautiful type prosthetic. And now we have put the implants in, we have hooked up a prosthetic, but I would still ask the same question I asked a minute ago. How do we transfer these 6 data sets to the lab? This is where the magic of my workflow is really, really exciting. And if you have been frustrated with the restorative process of full arch fixed implantology, you're about to have your world rocked. This is awesome. This is a game changer. It has completely changed the way prosthetics are working for me in the full arch arena. And it's easier, it's more simple, it's more predictable, it's everything I'd want it to be. And so I'm really excited to share with you how we're doing it today. Now, at first glance, pretty straightforward. I'm going to scan the temporary bridge, the temporary provisional, the temporary teeth. The temporary itself acts as a common point of reference for all of these data sets. We are going to take a couple of pictures so we can analyze the teeth relative to the face. But for the most part, it's just a temporary scan. So instead of all of these different data sets that the lab would have to relate to one another, all of the data sets are completely aligned because they come from one set of data. What do I mean? I mean, the implant position is known from the temporary tooth position is known from the temporary, the contour of the soft tissue is known from the temporary, and even the bite is known from the temporary. So the temporary itself represents all of these data sets, and I'm going to show you the way that we capture that in a very accurate, predictable way so that we don't have the lab trying to line up 5 or 6 different things. It's already lined up because it's just one digital scan. So here's the evolution of this workflow a little bit. I used to use powder and just try to spray the intaglio of the prosthetic. That would lead to a digital rendition where I could actually visualize, as you see right here, the multi-unit abutment cylinder here and there. However, that wasn't as accurate as we ideally wanted just because the powder and scanning internally was a little bit more complicated. So what we started doing was doing something like this. We would actually place scan bodies into the multi-unit abutment cylinders. But notice first, I did a reline impression in the mouth. So step one, patient comes in, time to restore. Basically, we're going to take a reline impression underneath the prosthetic. Then we remove the prosthetic and we actually place these, I call them reverse scan bodies. And those reverse scan bodies are a much more user-friendly way of scanning and getting an accurate representation of the multi-unit abutment position. So as you can see in that slide again, the scan body just screws directly into the multi-unit abutment. When I say multi-unit abutment, the multi-unit abutment temp cylinder. So what you're seeing here is a representation of the soft tissue, the teeth, obviously, the multi-unit abutment position, and the vertical dimension of occlusion, all in this one data set. So if we can scan this and we can scan it accurately enough, then just from that data set, the lab has those 6 pieces of data along with a photo to design new temporaries, to design final teeth, to design whatever you want. All of that data is now in their system. They can work with it. Now, I want to share an update or a different perspective with this you might be not familiar with, and that is relating to the accuracy of our scan data. And what I have learned over the years of working with different intraoral scanners and lots of digital companies working hard with this, as well as our dental lab, is that the way in which you scan actually affects the accuracy of the scan data. That was very surprising to me. I initially thought when this digital intraoral scanning technology came out, I thought if an image showed up on the computer screen, it was very accurate. And I'm here to tell you, I don't think that's the case. And the term very accurate, meaning, is this accurate enough that I can get a passive fit of a prosthetic? And I don't think it always is. So as you can see, here's an A, B, C, D option of how you might consider scanning. And in our experience, scanning like this, D, is the most accurate and it creates the least amount of distortion. And so this idea of kind of scanning buccal to lingual, back and forth around the arch, I think creates a wonderful 3-dimensional object that creates a much more accurate set of data than some of the other scanning shown in this slide here. So A used to be a really popular one, go all the way around the buccal and then all the way around the lingual and connect it. Doing quadrant scanning or sextant scanning is also common. But I think the back and forth methodology, buccal, lingual, shown in image D, is the most accurate way of doing it. Now, here's something interesting. This, I think, is the most accurate way of scanning, but I want you to appreciate going from tooth number 2 all the way over to tooth number 15 is a very long span. And something that DO came out with is a methodology to try to mitigate the scanning distance from number 2 to 15. Because if you took that blue line and straightened it all out, it's a very far distance, 2 to 15. So they created what's called a scanning block or scanning jig. And this jig has a unique geometry to it just for scanning purposes that will actually be composited, bonded to the back of the prosthetic like you see here. And that will actually create a full circle scanning process. So you'll go to tooth number 2, let's say, all the way around the arch and then back into number 2 position, completing a full circle. The process of completing a full circle in the scan, we believe, creates a more accurate data as well as decreasing the overall distance, because now the scan data is, if you will, more proximal to each other. So here's what this looks like today in my digital files. I will scan the temporary, but I'm scanning it now with this digital methodology of using the scanning appliance or the scanning block. Sometimes I refer to it as the scanning Lego, kind of looks like a Lego. And this again creates more accuracy. And so what you're seeing on the screen right here is everything you need to do restorative workflows. You're going to remove the teeth, do a reline impression, then you're going to place the scan bodies, you're going to place the scanning appliance, and you're going to scan the entire object. Then you're going to take the object back apart, put the prosthetic back in the mouth, and record a bite like you see in the lower right image. And then another double check that DO has implemented just to double check the accuracy while the prosthetic is out of the mouth, you can also scan the edentulous arch just as a verification for alignment of tissue, just as kind of a triple check that everything lines up right. So these pieces of data right here is all you need to go to final restoration. And the accuracy of the scanning appliance makes it where more users with a more variety of skill sets of scanning and a variety of scanners can enjoy a more predictable outcome. Because I also don't think all scanners are created equal. I think there's some that are more accurate and others that struggle more, especially with the full arch scanning. So now all of that data, the 6 pieces of data that are needed, are all seen in this slide right here, except maybe the photo of their smile. We do want to visualize the smile photos so we can plan teeth a little bit different. But basically everything you need is right there. So now this data can go to the lab and they can align everything with perfect relativity of each other. So where the multi-unit abutment is relative to the soft tissue, relative to the vertical dimension of occlusion, relative to the temporary tooth contours is all positioned together in one data set. There's no problem lining the data sets up on top of each other. And by doing that, we have really accurate data. With accurate data, we can begin planning the case with confidence. There's another representation of a digital scan of the soft tissue. So now, as you see in the top, any changes from the first teeth that were delivered the day of surgery can be proposed to the dental lab. And those changes are easy to communicate because they are all based on a tooth design that the lab already designed. So changes are made relative to a tooth position already known by the software. When you say move the midline 1 millimeter to the left, they know exactly what that means because they planned that midline and those teeth. They just open back the file, open it back up, and they begin planning where they left off, so to speak. And so all of this data can be visualized together, and then changes can be made in a way that it's predictable. There's no surprises, so to speak. And then I look at this situation right here. You just scanned the temporaries. If big changes are wanted, you might consider doing a secondary temp. If small changes are needed, you might go to final with those small changes made. But I think it's analogous to like a denture try-in for a conventional denture or overdenture. We often do a wax try-in so the patient can see the teeth. We, the clinician, can review and analyze some of the parameters that we're looking for. And the patient says, yes, I like it, or no, I don't. I like that methodology for fixed. And now with this prototype workflow, we have that same methodology. And so you need to ask yourself, okay, am I going to make big changes or little changes? If it's big changes, we probably want to do a secondary temp. So that's the question, new temp or go to finals. What I love also with the DO workflow, after you scan it, part of their package for full arch is a secondary temp included. And so if you did scan it, but you still want to stay in the prototype phase before you go to final teeth, they will send you a prototype set of teeth that look just like this. This is the second temporary. It comes with the multi-unit abutment cylinders already in the teeth. So it's just a screw retained, you pop it right in, and then you analyze the changes that you wanted. And the changes could have been anything: tooth shape, tooth size, tooth position. It could have been the shade of the teeth. It could have been how far forward they are here or there. The bite could have been opened, a more hygienic kind of pontic shape. All of that can be done and changed from prototype to prototype. So this is an example of a secondary prototype for a patient that probably wanted a few minor changes, and I wanted to have the lab make it, give it to the patient so we can better represent what the final teeth could theoretically look like. So basically we're giving this a patient and saying, try this on, see what you think about it. If you like it, awesome. If we make more changes, we can modify it, but now we're modifying it based on an updated temporary. So this is what I mean by a linear path. The first temporary is helpful in designing changes and modifications for a second temporary if needed. The second temporary is helpful for representing the next set of teeth. And if little changes are made, it's also done relative to the second temporary. So I'm never starting over, designing things all brand new from scratch. We're always designing from the relative previous set of teeth, moving in a linear fashion. Then when you've met all of your clinical objectives and the patient is happy with their function and aesthetics, then we move to final. A titanium bar is milled, and then a zirconia sleeve is over the top of that. And the final design is again exactly a replica of what was given with just minor changes. And then here's what those final teeth can look like. And so this workflow for me is more efficient, it's more predictable, and it's just frankly a lot easier to wrap my mind around. The diagnostic gathering appointment is a short appointment, it's an easy appointment, and then we're always able to give the patient something very close, if not identical, to what they're asking or requesting because of the linear nature of the workflow. And so what an exciting time to be part of full arch implantology, where digital is taking over. DO is leading the way with some really cool workflows, solving things like scanning accuracy issues with their reverse scan body or the dental scanning appliance. These solutions provide me a lot of clinical confidence to treatment plan this stuff for my patient and then know that I can deliver because I'm partnered with a solution-based company, an A to Z solution that helps me plan the case, helps me do the surgery, give it temporaries, and then restore it in a fashion that's predictable and straightforward. And so I've been a big fan of it. I'm real grateful for where we are in dentistry, that we can offer this to our patients. And I'm grateful for your attendance. I thank you so much for listening and being part of this. If you're ever around Utah area and want to take some dental implant CE, we'd love to have you here at Whitecap Institute. But thank you again, and best of luck with your clinical cases.